from the Global Hospital, Mumbai.
This meeting is being recorded.
Dr. Chaudhary from Sheffield Teaching Hospitals, NHS Trust, Sheffield, UK. And today we have the speakers, Professor Datta Muzumdar from KM Hospital. He will be talking on the techniques and implant of supramarginal resection on outcome, impact on outcome. Professor Ali Asgar Moyadi, he will be talking on the role of newer intraoperative adjuncts in improving GTR rates. And third speaker is Dr. Puneet Laha. He will be talking on minimally invasive glioma surgery. And we have the panelists, Dr. Shyam Babulkar from Orange City Hospital, Nagpur, Dr. Mazda Turel from Wockhardt Hospital, Mumbai, Dr. Abhida Shah from KM Hospital, Mumbai, and Dr. Meghna Chaugale from Shanti Pathology Laboratory, Kolhapur. Friends, it's an appeal to all to register for our MCNS conference, which is going to be held in Mumbai in February, as the early bird date is going to expire on 1st of next month. As you know, we are arranging this conference in a high-end hotel, Taj Mahal Palace, Lobar, and it's an iconic hotel in Mumbai, and it's a quite expensive hotel, so it is difficult for the organizers to reschedule the dates of early bird registration or give any concession in the registration. There are some difficulties in registration, as I saw on WhatsApp group of MCNS. So I request you to contact Dr. Athawale and Dr. Jagdane directly. They will be helping you to register. And for today's webinar, we have got wonderful topic and experienced speakers. I believe that everyone will be benefited with our topic and today's discussion. Also, I want that for the webinar, let the speakers should be from rest of the Maharashtra and panelists from the Mumbai. For the next webinar, it will be on the hydrocephalus. The topic will be declared shortly on the MCNS group. So I request Dr. Suresh Sankla to take over and start the webinar. Thank you.
Thank you, Dr. Dunnaji, for this nice introduction. And on behalf of our webinar committee, I would like to invite everybody for the subsequent months webinar and welcome you all to this webinar, which is on glioma surgery, one of the favorite topics of all of us. Let us start with the first speaker, and I would like to invite Professor Majumdar to please share your screen and start your talk, which is on the supramarginal dissection of the gliomas. Yes, Dr. Majumdar, please.
Thank you. Thank you. Thank you, MCNS. Dr. Suresh Sankla, Dr. Kishore Chaudhary, and Dr. Babu. Am I audible?
Can't hear. Not very clear, yes.
Yeah. Now can you hear me?
Better.
Yes. Yeah. Okay. So the topic given to me, and Dr. Sankla correctly mentioned that glioma surgery is the most common surgery, and it is most surgery which is where the window to the residents also for training and
can't hear.
So seasons. Hello.
Yeah.
I think it is a little bit the internet connection. I think is a little bit issue. You can hear me, right? I can continue.
Yeah, intermittently.
Yeah.
When you start, and after some time it goes out.
Yeah.
Go ahead. Let's see how.
Okay. Yeah. So basically, what we know in gliomas. So we know that there are two types. So there are low grade and high grade for general purposes. So low grades are very localized gliomas, they're DNET ganglioglioma. oligodendroglioma, and DI, desmoid-positive infantile ganglioma, PXA, etc. And the ones which we are worried about is the diffuse infiltrative, the malignant gliomas, which are grade 3 and grade 4. Grade 4 is glioblastoma. And we know also that the WHO update of 2016 has completely changed the paradigm and the classification of gliomas. And now it is more of molecular based. So we do usually the IDH, the ATRX, and the 1P19Q. And then, if required, we do the TERT mutations and P53 and so on and so forth. So molecular neuro-oncology is one thing which has substantially changed the overall management of gliomas, I would say. So glioma is not only surgery based, but we need to work in a multidisciplinary fashion. And we are obviously worried about recurrences versus pseudo progression, and how to manage these recurrences, when to recurrences, case by case basis, and so on and so forth. Largely, I'm going to talk here about the malignant gliomas, grade 3 and grade 4, because localized low-grade gliomas, there's not much of a dichotomy. So mostly grade 3 and grade 4 gliomas we know are incurable, but local good control enhances quality of life. That is our paradigm. The overall survival of GBM remains dismal, and the median survival is about 15 months. It has not changed significantly in the last 10 years. Out of all the temozolomide and the newer agents like Avastin and everything, all, and also this thing, the GBM survival has still not changed. Only thing is that the 5-year survival is about 9.5%. We know that surgery for gliomas or surgery for brain tumors is important in general. This we had analyzed way back in 1989, and we had 40% mortality at that time and 20% morbidity rate. So you can imagine that surgery for Lobar lesions is not, in young children, is not very easy, and we need to get our act together to manage this and approach these issues. I had written a small editorial in the International Journal of Cancer, and at that time I had mentioned that it is a continuing challenge and a mystery. It still remains after 12 years' time, after more than 12 years. And I had mentioned that we should call this as glial infiltrative disease rather than a glioma. It is an infiltrative disease. Whatever we may do, the tumor extends beyond our what we can see and what we can even radiologically perceive or even operatively perceive. So still, this remains a mystery. And the goals of surgery, now we have this oncological control of the tumor by maximal resection and functional preservation. These are the two important words. So everybody resects a glioma. Everybody removes some part of tumor and reduces the edema, reduces the mass effect, the patient becomes better. But is that enough? No, in the last 5 years, things have changed a little bit more radically. So now we are looking at maximal resection and functional preservation, but at the same time avoiding neurologic complications. So survival is now dependent upon the age and most importantly the extent of resection. We have to have the preoperative and postoperative KPS, adjuvant therapy, response to adjuvant therapy, and the molecular status, and whether the tumor is close proximity to the ventricles. So here there are landmark studies. So here from the surgical journey has started way back from MD Anderson, when they mentioned that the Savaya group had mentioned that we should resect more than 98% of the tumor. Then only we have some degree of overall survival, change in the overall survival. So this was a landmark paper, and at the same time, Mischberger from San Francisco also reiterated what that was almost about 10 years later. So this paper by MD Anderson group was done in 2001, and in 2011, Mischberger said the same thing, that extent of resection for newly diagnosed GBMs or malignant gliomas impacts outcome. So far and so forth, we have been concentrating that we should resect the tumor maximally. There is no controversy in that. So now, in the last 3-4 years, there is a new concept which has come as supramarginal resection or supratotal resection. Now, what is it? Now, normally we have most of these gliomas are enhancing. We have the contrast enhanced glioma area, And normally we concentrate on the contrast contrast enhancement. So that part of the glioma we receive. But here in supramarginal resection, we go into the beyond the contrast enhanced margin. So T2 flare image is given importance. So we say that there has to be a T2 flare image for flarectomy. So the area which is depicted by the flare images should be removed. So here you can see that there is a small lesion. This is a malignant lesion in the supramarginal gyrus, and the lesion has been extended. You see the margin of the resection. It is well beyond the supramarginal gyrus, and obviously there are some adjuncts which have been used, which I will come to enhance this resection. So here you can do the supramarginal resection using lot of adjuncts. So this is one case where this suprainsular lesion, and you can see that the dots on the surface of the tumor is all the tracks. So you use white fiber tract anatomy, you use intraoperative mapping, you do use electrical stimulation, and you can see that using that the tracks around the tumor has been preserved. So the tumor has been removed, but the tracks, the red tract, the superior longitudinal fasciculars, the arcuate fasciculars, the IFOF, the thalamocortical body. This is a whole new you need to understand the white fiber tract anatomy for that. So this can be preserved. So oncology control as well as functional preservation. So how did this supramarginal resection concept start? So initially, if you can see, Walter Gandhi reported 5 cases of hemispherectomy for removal of gliomas in the right side of the hemisphere because they were coming with intractable epilepsy. So he just removed the hemisphere. So in that patient, the seizures stopped, but the patient became hemiplegic. However, there was no improvement in survival rates. So the concept of supramarginal resection has come way back from 1928, but it was just a concept. And then it came to gross total resection, just with I mentioned that it is mostly the enhancing area which has been removed. Now we remove the T2 flare. The concept is to remove the T2 flare MRI. We say that it improves survival. And Dufa was the first person who actually started it and popularized it. So he did a lot of mapping and he did an extensive resections, and there are promising results in patients with low-grade gliomas. And when considering flarectomy, there is much less agreement. So basically, it is good to say that I want to remove the entire T2 flare area, but at the same time, we should understand that how much to remove. If we remove the entire T2 flare area, we are in for complications. So the concept is that the resection should be somewhere between 20 to 60%. They say that more than 20% gives definite benefit, and more than 60% does not give any benefit. So your resection of the flare signal on T2 somewhere should be between 20 to 60%. It is most effective in IDH mutate gliomas. That means the IDH wild type GBMs. So these are the gliomas which are the results are supposed to be better. So if you can see here that in these cases, there is no controversy in lobar gliomas as far as the temporal and occipital or the frontal is concerned. So you can see here that you can straight away do lobectomies here. So doing the lobectomy, which we used to do, which we are doing, which you do in the past, is like a supramarginal resection that we are doing. Surgical advance is the aids that we are used for doing the supramarginal resection are Ali is going to talk about that. I will just mention it. Fantastic. It is real time. It is effective. It is cost effective. It is easily available. So you can use a navigated ultrasound, 2D ultrasound, 3D ultrasound. You can use intraoperative MRI, DTI, white fiber anatomy, awake craniotomy, mapping, cortical stimulation, subcortical stimulation, and obviously the fluorescent guided dissections. And now what is the new concept is the connectomics. So here you can see that now they are using a combination for resection of the gliomas. For example, this paper recently published in 2016 has used the DIVA protocol. That means they have used intraoperative MRI combined with fluorescence. So if you can see that normally here the complete resection with where the fluorescent there would be no fluorescent injection or a vague fluorescent injection, we would stop. But nowadays we are doing intraoperative MRI doing fluorescein, and we are combining both, and we are doing a supracomplete resection. And you can see this is the final result, where using intraoperative MRI and a combination, the median survival time in GBM is decreased by months. So these are isolated reports or cases which cannot come as a algorithm, but people are trying, different people, where intraoperative MRI has been used with fluorescence. Connectomics. So connectomics is something which is using now a software based data analysis of white fiber tracks. So here you can see all the tracks are mapped in different color, and this is a tumor in the supplementary motor area. Now you can see that the various tracks are marked. So the frontoascending tract, what is the frontoascending tract? The frontoascending tract is which with the corticospinal tract and with the SMA syndrome, we can definitely try to avoid SMA syndrome in a SMA lesion. How do we do this? We do connectomics. So connect the software is where all the white fiber tracks are mapped. We get already a normative data. You can see here on the right side that this red sided track is, you can see that it is in the front of the tumor. It is also on the sides of the tumor, and this blue tumor is the corticospinal tract. So using this connectomy, you can see that this is the tumor and this is the tract which we are worried about. Now, in general, if we don't map this and if we remove this tract, then the patient is definitely going to have an SMA syndrome. But with the use of connectomics, that the big data network analysis, we can identify this tract and maybe try to avoid injury to this tract, and so that we can decrease or minimize the incidence of SMA syndrome. So supramarginal resection, there are few select articles in the literature of in the last. Now they are trying to seek a data where how this T2 flarectomy is going to affect the overall survival. There is still no consensus that T2 flare signal excision overall improves the survival. There is still debate going on, and we have to wait for the consensus. So here, if you can see, the supramarginal resection is definitely advised in low-grade gliomas and highly diffuse IDH wild-type gliomas. And there are certain MR sequences which allow you to sort of predict whether flarectomy is going to help or not. So then you have to be in conjunction with your radiologist also. Now, flare can be either tumor, it could be either edema, it could be infiltration. There is a conflict there. So subventricular zone also. So normally, if there is a contrast enhancement in the subventricular zone where the glioma arises. Now, if there is a flare signal which is going towards the subventricular zone, are we going to excise? We are still not sure whether that flare signal which is there in the subventricular zone contains tumor tissue or it is just edema. So that research is going on. So as I mentioned, you have to have an SMR within the range of 20 to 50%. Eloquent versus non-eloquent, non-dominant versus dominant location matters. There is complete agreement for doing an SMR in right anterior temporal and right frontal lobe lesions. And what we don't need, what is the pitfall of SMR is that the worsened post-operative neurological performance completely defeats the survival benefits from the complete tumor resection. If you are going to do a supramarginal resection, supratotality neurological defect, because it defeats the entire purpose of the surgery. So here you can that there are various combinations, as I just mentioned, the DIVAS protocol, where intraop MRI is used with fluorescent, and you can use intraoperative mapping. You can also use Raman spectroscopy, which has been shown to be used to identify tumor tissue from the healthy tissue, and laser endomicroscopy is also used. So, as I just mentioned, the negative prognostic factor for this is severe post-operative neurological deficit. So, when we do a SMR, we have to be sure that we are going to preserve the function. So here this data is beautifully depicted in the literature. So various groups have done it. So they, in general, the consensus is that in IDH, wild type, obviously non-eloquent area, there is no question. Non-eloquent area, you can do a chest resection. So that we all are doing. So all these groups are definitely advocating, or they have found some survival benefit with supramarginal resection. And you can see here that this alerts to the possibility that in different studies, how much this study is effective in what manner. So there are few studies which have been analyzed, and they have found out the HR, the statistical ratio is 0.64 towards SMR in those cases which I have mentioned. So I'm not going to go too much into detail. Awake craniotomy definitely has its own advantages. You can do aggressive resection and patient is awake and alert. So it should be practiced. You can do all kinds of mapping as well as intraoperative real-time imaging while the patient is awake. And you can definitely, patient benefits from awake craniotomy, where with minimal neurological deficit, patient can resume the activities. There is better quality of life and financial benefits as well. So intraoperative neurophysiologic monitoring, absolutely essential. There is no now two ways about it. We have to do SSCPs, MEPs.
I'm sorry, Datta. I'm sorry, Datta, to interrupt. The time is over. I'm sorry.
I will just conclude.
Okay, no problem.
Okay.
Okay.
Yeah. So here there are various ways now. Sometimes people are using transcranial magnetic stimulation with tractography. This is whole again a system, an idea which is being put forth, and they are using indocyanine green also, the ICG, for resection of gliomas. So that is also in evolution, and I would say that definitely there has to be a balance, oncological functional balance that we have to maintain and in the future. And definitely SMR has a place still under observation, and there is still not a confirmation for it. Thank you very much.
Thank you. Thank you very much, Datta, for that excellent and succinct presentation and updating us about all the nuances of glioma surgery in such a short time span.
Yeah.
Well, I think before, instead of taking questions now, Datta, we will let all the speakers finish, and then we can direct the question to all of you together or specifically. So let's invite Professor Ali Asghar Moiyyadi. As we all know, as soon as we talk about the glioma surgery in Mumbai, one name comes to mind very quickly is Ali's. So without wasting any more time in further introduction, can I request Ali to start? And we got 15 minutes. So thank you very much.
Yeah, sure. Thank you, Dr. Kishore and Dr. Sankla and the entire MCNS committee. Can you quickly allow me to share my screen, please? I need to be enabled to share the screen.
Yes, you have the right, sir.
Yeah.
But simultaneously, I would also inform you that your bandwidth is very low.
Now, can you all see my screen, please?
So your bandwidth is very low. If you could close your video and talk, that would be much better, actually. I could see red lines. Your bandwidth is very low, sir.
Okay.
Yes, that's better. We can see now.
Yeah, okay. So I will do that. I just need to. Are you able to see my screen? And
screen is visible, sir.
Yeah, okay, fine. All right. Thank you, Dr. Datta, for setting the stage. And what I'll do is I'll just carry on from there and discuss about intraoperative adjuncts. Now, I think Dr. Mazumdar very nicely showed the role of extent of resection in gliomas. I think there's no doubt about it. What's important to highlight is that this is the one of the only modifiable prognostic factors which we as neurosurgeons can alter favorably for the patient. There's the controversy of how much should be removed. Dr. Mazumdar alluded to it. And I think there are many studies, I won't go into those again, but I would just like to mention this one study, which shows that it does not matter whether you remove that 78% or 98%. Those are all statistical numbers. What this shows is that for any given combination of prognostic factors for a patient, any incremental improvement in the extent of resection is beneficial. So the bottom line is that the more you remove, the better it is, but not at the cost of neurological morbidity. And that's why we always aim to perform a safe maximal resection. There is this complex interaction between the extent of resection, morbidity, and the survival. A reduced extent of resection adversely impacts survival, as does an increased morbidity. This is a lesser known fact that increased perioperative morbidity leads to overall poor survival. And to top it all, there is also an interaction between suboptimal resection and an increased morbidity, what we describe as or commonly know as the wounded glioma syndrome. On the other hand, an overzealous resection, if you extend your resection thinking that you will improve survival, but you'll end up in morbidity, can impact adversely the survival. So what we want to aim for is to improve extent of resection and reduce the morbidity, which would actually translate into the best improvement in survival for the patients. So if that is the case and that's our goalpost, then how are we doing as neurosurgeons? I think there are challenges, all of us acknowledge that, but resecting intraaxial tumors, there is the diffuse infiltrative nature and difficulty in visualizing tumor extent. At the same time, we still need to get maximum tumor out and not make a mistake and damage anything eloquent which is lurking in the vicinity. And therefore, to optimize glioma surgery, you need to have a combination of technique and technological adjuncts. Before I go to the adjuncts, I'll talk a little bit about the technique of glioma surgery, and this is based on the understanding of the pathogenesis, the origin of gliomas in the subcortical white matter, the spread along white matter tracts, and very importantly, the respect of gliomas to pia, which is actually a very resilient barrier which prevents the spread of the glioma across gyri. If the glioma spreads across gyri, it's because of the spread along the U fibers, but does not breach the pia across the sulcus. This is important because it also helps you resect the tumor better. And the technique of subpial dissection and en bloc or circumferential resection actually utilizes these basic anatomical principles. So you have a tumor in a gyrus, you localize the tumor. If it's not visible but to the naked eye, then you need some kind of adjunct. We'll talk about it. And then you isolate the gyrus. You do a subpial resection, as you can see in that video there. And then in the deep white matter where the gyral bank ends, you have to do white matter dissection. The advantages of doing such a resection is that it is anatomical. You remove the entire gyrus and therefore it's radical. It also is safe because you're not damaging the adjacent functional gyri mechanically, nor are you damaging it by causing ischemia because the sulcal vessels will be traversing the gyrus, the sulcus, between the two pial membranes. And if you preserve the pial membrane, you are less likely to damage the vessel. It's eventually more cosmetic and an elegant way of removing gliomas. So it's probably not enough just to do a lesionectomy or even an en bloc removal margins. What we should be aiming for doing is to remove the whole gyrus, which is involved by the tumor because there will be microscopic tumor around it. And in case of tumor which has spread along the adjacent gyri, then you do a multi-gyral en bloc resection, and this can be extended to the concept of supramarginal resection like Datta mentioned. Here, the bottom line being that you have to map the subcortical white matter tracts and resect all so-called even normal brain tissue till you reach functional substrates. So even if you use all these techniques, is it still a foolproof way of achieving your intended goal? Well, it seems that it's not. And more often than not, neurosurgeons, when we estimate the extent of resection intraoperatively, land up actually overestimating it. And this is the study, but there are many others which show that in almost 2/3 to 3/4 of the cases, 60 to 75% of the times when the neurosurgeon reports a complete resection, MR detects residue on the postoperative scan. which means that there is a discordance between our planned extent of resection and the actual extent of resection that we land up achieving. And this is because of those inherent problems in localizing the tumor and making inadvertent mistakes or not picking up those residue. And therefore, we have to turn to some kind of aids to enhance our human capabilities. And this is where the adjuncts come in. There are adjuncts which help you maximize resection, and there are those which help you preserve function, and both of them need to be used complementarily. However, there are some very, very basic adjuncts which are not really technological. Neuroanatomical knowledge and landmarks are very useful and a very reliable navigation. And this is something which all of us learn in neurosurgical residency and which should be applied regularly. Then you have the navigation, which is the GPS system, which we all like to use and probably all neurosurgeons are acquainted with. However, since it relies on preoperative MRI, we need to understand that there is this problem of brain shift once the dura is opened, and therefore for all intraaxial tumors, it will fail, the accuracy will be lost. So except for perhaps localizing the tumor while you're doing the craniotomy, it cannot be really used in order to continue with the resection as a resection control tool. The gold standard would be intraoperative imaging, and the intraoperative imaging tool which is the best is intraoperative MRI. This is the gold standard. It allows real-time imaging and is also the imaging modality of choice. And this has been demonstrated in multiple studies. However, this is also dogged by the problems of infrastructure and man cost. There are long acquisition times leading to logistical challenges during surgery, and therefore it is not available widespread in most neurosurgical centers. On the other hand, you have the intraoperative ultrasound, which is a very, very easily available tool, available in most departments, maybe not in neurosurgery, but in radiology. And it is quite cheap, and it is something which can have multiple applications during surgery, both as a localizing tool as well as a resection control tool. And technology has evolved to a point where images produced by the ultrasound are sometimes as good as the MRI. In our own experience, and we've been using this for over a decade, we found both the 2D and the navigated 3D ultrasound very useful. The 2D is used more often than navigated 3D, but when it is a question of resection control and residue detection, we tend to prefer the 3D navigated ultrasound, though a well-done 2D ultrasound can also be equally useful. And the application has been for not only localizing and biopsies, but as a resection control tool, more so in non-enhancing tumors where other forms of adjuncts like fluorescence may not be very useful. As a resection control tool, what we realized is that when you use an ultrasound for updating your residue status intraoperatively, what we call as intermediate resection control scans, we have detected unanticipated residue, something that we would have missed otherwise in almost 40 to 45% of the cases, leading us to resect further and therefore improving the extent of resection, and by virtue of the prognostic role of extent of resection, thereby improving the oncological outcome of the patient. And this is as accurate as can be for most adjuncts, and with a concordance with post-operative MRI at a very high 80%. The gross total resection rates which we were able to achieve were at par with those in literature reported for other intraoperative imaging modalities. If you were to compare head-to-head the ultrasound with the MRI, there is no doubt that the MRI is extremely better in terms of image resolution and orientation because it gives you multiplanar view, actual coronal, sagittal, full head view. The ultrasound does not do that, but if you have a navigated ultrasound, then it overcomes those limitations. And then to top it all, there are advantages with the ultrasound like the cost effectiveness, quick, able to do repetitive ultrasound scans within minutes without disturbing the workflow, especially when you're doing cases like awake surgery, where moving the patient in and out of the MR may be challenging. And the subjective nature of the ultrasound can be easily addressed by adequate training, and the use of navigated ultrasound shortens this training curve. And in our experience, it's a very useful adjunct with other intraoperative imaging modalities, especially in gliomas, where it is always better to use a multimodal approach. For example, in fluorescence, and Dr. Datta did mention it about dual visualization. In our own experience, we've used ultrasound with the fluorescence. The fluorescence shows you the contrast enhancing part well, but the ultrasound shows you the non-enhancing, the flare T2 component, which you can resect. And you can combine it very, as I already mentioned, easily with awake surgeries, which we do routinely for mapping, because that is ultimately the functional limit at which you will stop your resection. Moving from the adjuncts which help you image, other adjuncts which give you optical imaging, and these are different kinds of optical imaging tools in neurosurgery have been tried. You have diffuse reflectance spectroscopy, but it is really not very specific and does not have discriminatory value. What is more routinely used is fluorescence. And then you also have vibrational spectroscopy, which I will not talk about, but which is an up and coming field, especially Raman spectroscopy, which is actually does not require any external dye. However, what has been used and is now standard of care in high-grade glioma surgery is fluorescence. And the most common used fluorescence is aminolevulinic acid induced fluorescence. All of us know this. It's a prodrug, a dye which is to be taken orally, gets converted to protoporphyrin 9, where it gets arrested and does not go ahead to become heme. Protoporphyrin specific for gliomas, and it accumulates within glioma cells. And when it is illuminated by blue light, it appears to fluoresce. That's how you resect the tumor. And this has been proven in randomized controlled studies, where the landmark study almost 15 years, the GTR rates, and also improves the progression-free survival, though the study was not powered for survival. On the other hand, you have some other fluorophores, fluorescein being the other one. It has been used much earlier than ALA. Earlier, it was used in very high dose and visualized by the naked eye. And now you have more refined protocols using lower dose fluorescein with a microscopic filter. However, it still remains non-specific because it's an extra cellular dye which disseminates and dissipates in the extracellular fluid, and you have to be careful. There are issues with timing of the administration of the dye and the specificity, and though it's cheap, you have to be a little cautious while using it for tumor surgery. As I mentioned, combining modalities is useful because fluorescence is a surface phenomenon, whereas imaging with ultrasound or MR gives you depth perception. And if I were to compare this crudely, this is not an objective cost-effective analysis, but a subjective one. I would say that the ultrasound actually scores better over both the IOMR and the ALA, purely because of the high cost of the infrastructure and MRI and the high cost of the dye in the ALA, and that's what kind of limits their general applicability. Just shifting gears for the last couple of slides, we need to extend the resection. Yes, we all acknowledge that, but not at the cost of function. And often what we realize in gliomas is that there is a conflict between the tumor boundaries and the eloquent substrates. We all assess this preoperatively using various techniques, but you must remember that preoperatively assessed eloquence is not always necessarily correct, as this study showed. Almost 35–40% of the cases which were presumed to be the eloquent, when actually mapped, did not turn out to be eloquent. And therefore, you should always confirm eloquence intraoperatively by mapping. And how do you do that? You could do that asleep and awake. When you do it asleep, both of them utilize electrical stimulation, but how they record and interpret and monitor the responses are very different. In asleep, you monitor mainly the motor pathways. You could do the sensory and the brainstem auditory work also, but all of them record electrical potentials. There's a little complicated machine that you need, and the neurophysiologist preferable. On the other hand, awake utilizes bipolar stimulation, simplified machine, and actually you would prefer to have a neuropsychologist to help you understand and interpret those tests. There are different techniques of doing that with a sleep, and especially subcortical mapping, which is very important. It's not cortical mapping, but it's subcortical mapping, which is more important because that's your functional limit of tumor resection. And awake, of course, is also a very versatile tool, especially because it lets you map many more things beyond motor, language, negative motor movements, cognitive memory, etc., etc. And if done well, it is very reliable, and most patients will cooperate if counseled well for awake surgery. Finally, I would say that the choice or the bouquet of adjuncts available is vast, and it's a choice which you need to judiciously exercise. This is a flowchart and an algorithm which I would like to use depending on the tumor delineation, location, and the aim of the surgery, along with eloquence. Remember that we have come a long way from the early operating theaters to a very technologically dependent operating theater. And I think it's very important, if we have to optimize glioma outcomes, to be able to use this and not just relegate them to the state-of-the-art domain, but make them standard of care. It requires a little bit of training, but I'm sure as neurosurgeons, we're always up to it and can do that, because eventually well-equipped is well-prepared. I'd like to end by this one slide saying that gliomas are something which all of us as neurosurgeons operate on, are a formidable surgical challenge, and should not be belittled by saying that it's just a glioma. External resection is very important and needs to be optimized. Correct technique, right intent, and appropriate and judicious use of adjuncts will help us optimize these outcomes. Thank you very much.
Sorry. Thank you very much, Ali, for that excellent presentation as usual. I think I'm sure there are lots of questions, but we will leave them for later on. And without wasting any more time, let's invite Mr. Punit Plaha from Oxford to talk about minimally invasive techniques that he uses for maximal glioma resection. I've been myself waiting to hear his talk for quite some time now. So he is in the middle of traveling, I'm told, but I'm sure he will have been able to log in and talk to us. So Punit, over to you, and please share your screen.
Yeah, thank you, Kishore. Thank you, Suresh, for asking me to give the talk. Apologies. I'm sitting in a service station next to the highway. So if you can hear me well and see my screen, I will can you hear me well?
Yes, we can. And we can see your screen as well, quite well, Punit.
Thank you. So I'll give a slightly different flavor. I think the previous talk by Dr. Moyadi was excellent in talking about it. And I'll add one more to this. Talk about endoscopy. And I will say, as I go through the talk here, with our cases, we use a lot of, as you know, in the UK, we use 5A layer standard, we use DTI, and it'll become a flavor of the talk here. This is exactly as the previous speaker had mentioned. In glioma surgery, intrinsic tumor, you need to try and find this balance between tumor resection and neurological deficit. The more you remove, the better for survival. Give them neurological deficit, it affects their survival. So, and I think we heard this as well, the concept is now moving to functional connectomes. We rely a lot, all our patients who have intrinsic tumor surgery get DTI, most get functional MRI scans to try and understand the functional collectome in relationship to the tumor. Now, we've sort of heard this multiple adjuncts, like I said, very nicely summarized in the previous talk. I'll give a different flavor with a new adjunct with, not a new adjunct, it's been around for a while, with endoscope-assisted surgery for gliomas. Now, I suppose the key difference between the endoscope and microscope is the angulation, the 30 degrees, 45 and 70 degree endoscopes. Operating with a 45 degree and a 70 degree endoscope is challenging with work, and your instruments are not really geared up to it, but a 30 degree because your instruments work within the range, you get a wider angle of view compared to the microscope. This is a good example. You look at a right frontal lobectomy. This is a microscopic picture. I won't say criticism. I suppose one of the relative drawbacks of a microscope is slightly reduced illumination at depths. And your line of vision is straight with the microscope because the light travels in a straight line. The endoscope, because you can move it deeper into the parenchymal tissue or any other part of the brain, you get good illumination with the eye close to the operative field. And obviously, the same area, if you then put in a 30-degree endoscope, you get a much wider view beyond your straight line of vision. Now, how do we use this to our advantage? I'll talk through a series. We've done over about 200 cases over the past 6-8 years. It's an endoscope-assisted technique, so use your standard bimanual surgical techniques, 0 and 30-degree endoscopes. We don't use it, and I'll talk about it later. Use both GA surgery, awake surgery, white light, 5-LA guided resection. Two things you can do. You can do a forehand technique where you operate both hands and your assistant hold the endoscope with you. That's my preference. We've also used pneumatic endoscope holders with a 2-hand technique. The advantage of a forehand technique, as we know with other endoscopic surgery, is the movement of the endoscopes give you that depth perception, the proprioceptive feedback, which is, I think, better than just a pneumatic fixed holder. Now, the question I get asked is, how do you prevent forehands from clashing, which is because your opening is very small? And I've sort of put this clock face here as an example. Simple rule, if you use the 30-degree endoscope, if the endoscope is positioned at 12 o'clock, you operate at 6. If you want to operate at 9, you assistant hold the endoscope at 3, just opposite, 180-degree opposite, so that there's no clash. This is the setup. Myself with an assistant, we are doing a procedure. We got the endoscope screen in front of us. We actually use the ultrasound at the moment. The front, and there's a navigation system you saw at the back. And I've just sort of put the microscope in the background draped, and we rarely use it, but that's part of the standard operating setup. Use neuronavigation in every case. I appreciate there's brain shift, but even intraoperatively, good to tell you spatially where you are within the brain, especially with wide fiber tracks. You can use your incisions in different parts of the scalp, even eyebrow axis, and I'll show some examples and where possible you approach. So I'll talk you through this video on an approach here. This is a patient with the glioblastoma or the geniocorpus callosum. So this is just to show an example, your technique. This is a bayoneted bipolar suction device. You're doing a corticotomy through the non-eloquent gyrus, as you normally would do, even with the microscope. Corticotomy is done. I line patties. And I keep the will regularly change tubular dilator. And then beyond that, once you have that access to the tumor, you use your ultrasonic aspirator. A curved long one is a good one. And then we have a malleable suction in one hand to to look around corners. You can use a malleable suction to to help with the operative field. So the point being that you don't change a microsurgical technique. This is using 5-LA fluorescence with blue light. You alternate the blue light with the white light as you operate, as you normally would with your microsurgical technique. So the technique doesn't change, but your visualization improves with the endoscope. Now, if I was going to put through the advanced,
I think, Puneet, we can't hear you. We can see your slides, but we can't hear you.
Can you
maybe yeah, we can hear you. Maybe if you turn your video off, so that probably in case the reception is poor. But share the screen and keep on talking.
Can you hear me now?
Yes.
Yeah.
Okay. Thank cavity and you have a glioma there. The cavity has created the space for you. So the endoscope is useful adjunct. I'll sort of show you just the hemangioblastoma just to make the point. This is a cerebral hemangioblastoma. You do a, and this is a 30-degree endoscope. You get a good view of the nodule inside. It's not a big opening. You do your standard resection as you normally would. Now, this is a good example. This is someone who survived 3 years with a recurrent glioma, 2 areas of recurrence. We felt there were multiple lines of adjuvant treatment, therefore we should offer resection. Now, you can resect the tumor component in the posterior temporal lobe on the right, but this is the difficult one because if you go transfer a parenchymal, you will damage the optic radiation lateral to this tumor nodule. So this is where we did an approach through the previous resection cavity up into the ventricle to find this nodule. I'll show you a video of this. This is the post-resection scan. And here you'll endoscope, we are to the superficial nodule. Find the second nodule within it. This of 5A comes in. I switch top left-hand corner. We picked up this tumor from the inside of the ventricle. You probably wouldn't have found it without the use of the 5LA fluorescence. In this case, it's 5LA and the intersection. This is another example where we've combined modalities. Young lady came in as an emergency. This microscopic because where a tumor has a large cortical presentation, you need to get your craniotomy to the same side. We did this endoscope resected as an emergency resection. The top left is the postoperative scan showing residual tumor where we had left close to the corticospinal tract. Given she was young, this is an IDH mutated tumor. She came back for a second endoscope assisted awake resection, and the postoperative scan with the DTI on the right side showing you can push a resection closer to the corticospinal tract, the previous large cavity there. Now, the second, I suppose, approach where it's very helpful is frontal lobe tumors with eyebrow craniotomy. Then I'll mention a couple of cases here. I will mention one is the relationship of the tumor to the ventricle, relationship with the frontal sinus to the grade 3 oligodendroglioma. I think is a favorable one for an eyebrow.
I think, Puneet, we are losing you again. We can't hear you.
To go through the frontal sinuses. I know some do because there is a risk of infection. I don't. And this is the post-operative scan. And this is just the video of the resection. Can you hear me, Kishore?
Just about, you're breaking up so quite a bit.
Can you hear me now?
Yeah, it's slightly better.
This is the ventricular system. These are different.
I think, Puneet, I'm sorry to interrupt. We can see what you're doing and we can see what you're trying to say, but we can't hear you.
You never get the height to resect them. So this is one I would resect through a mini crane out to me through an endoscope approach from the top. As on here.
I think you're broken up completely. Frozen. Screen is frozen. We can't hear you, Puneet. We can't see your presentation, nor can we see you, nor can we hear you. So
can you hear me?
are you?
Okay.
Okay.
Let's try. Okay, let's move this on. This is just how a eyebrow craniotomy is done. I'll move it on. This is just to show the scars heal very well. I'll make a point about frontal tumors where the endoscope is helpful, frontal and parietal tumors, especially tumor in the genu and splenium or the corpus callosum. With the genu, it's a helpful tool because you look around the curve of the pericallosal artery. With the splenium, again, it's good because it follows the curve of the splenium to the contralateral hemisphere. This is just showing a frontal resection. You can see after you resected the tumor, trying to separate the genu of the undersurface of the pericallosal artery. And you get a very good angulation with the 30 degrees because you can then see underneath the pericallosal to the contralateral hemisphere. The same applies for the splenium as well. Instead of the pericallosal artery, the key structure here are the internal cerebral veins. And the key is to identify them by seeing the preserved arachnoid, which usually is in the case with these cases. This is just resecting the tumor here. You'll see the arachnoid comes into play, and then you'll see the internal cerebral veins through the arachnoid, and these are the ones which need to be preserved. You get a very good angulation with 30-degree scope here. Interhemispheric approach, there's the natural corridors in the brain. The endoscope is a good tool to resect this. I'm just going to move this because I think my videos that don't play very well when it's on. This is somebody with the genu of corpus callosum tumor. Interhemispheric approach. Start off initially with a 0-degree endoscope down to the corpus callosum. This is a corticotomy in the corpus callosum, and then with the 5A, you can see the fluorescent tumor within the genu, which can then be resected with your standard microsurgical technique. The same with the splenium. Splenium tumors of the corpus callosum, you can access from interhemispheric, and we always have them tumor side down so that the ipsilateral parenchyma falls away from the falx, as in the tumor, as in the video here. Posterior interhemispheric approach, the falx is on the right. I'm changing between white light and 5A light to identify the tumor with the pink fluorescence. You start your resection, and then you continue as you with an ultrasonic aspirator. And again, you alternate with the blue light to pick up the fluorescence within the tumor. My last few slides. Temporal lobe tumors are challenging because of the number of white fiber tracts around them, especially on the left or in the right as well. You've got all your major tracts in the sagittal stratum, and therefore a lot of these patients have awake surgery. Tumors which are the non-enhancing gliomas involving the amygdala, hippocampus, and assisted awake as well, because the tracts are lateral to the tumor. And this is the sort of approach. You see the tracts here. You do an approach, the postoperative scan. You start by anterior temporal resection, and then you work medial to the tracts. And this is the postoperative DT on the right side, showing you can preserve the tracts by taking an anterior approach. Just a different way of doing, this procedure. Some more examples here. Again, here the tracts, the tumor is medial to the tract, so you cannot make a lateral approach. So you do a posterior interhemispheric approach from here to resect the tumor. And this is the postoperative scan at the bottom. So I think where temporal lobe tumors come, your approach depends on the location of the tumor in relationship to the tracts. These are tumors high up on the sagittal stratum, and with these, we take an approach along the temporal fossa floor and work up from below underneath the optic radiation. There's some examples here, pre and post DTI showing the optic radiation is intact, and so is their vision. Now, thalamic tumors. Now, this particular case, the endoscope is very helpful here. You can see the corticospinal tract lateral to the tumor, anterior and superiorly. This was done under GA with neurophysiology monitoring, motor evoked potentials, and 5LA fluorescence. I'll show you a short video of this. This is an approach through the superior parietal lobule. If you come medial on the superior parietal lobule on the right side, you do a transcortical approach. You enter the ventricle. This is the tumor being debulked within the thalamus. This is 5LA fluorescence. Within the endoscope, you can see the tumor there. And you continue your resection. I'll sort of move this on. This is the ventricular system. You can see now the tumor has been resected. We do continuous subcortical stimulation motor mapping as well for MEPs. This is some residual tumor identified, which you're not seen on the white light. You see it on the fluorescence to complete the resection. I'll sort of move on given time. Now, if you look at the top left picture, this is just an example to show you how these tumors are resected, looking at the functional map. Now, if you follow, I'm going to follow this postoperative picture showing the approach through this tumor to try and stay below the corticospinal tract. This is a postoperative DTI scan. That's the resection cavity, and that's the end of the resection of the small residual next to the DTI tract. So it's a multi-adjunct approach to try and resect these tumors. There are loads of publications on this topic over the last few years from our side. I think there are 5 papers. UK has got a socialistic healthcare system, so length of stay is important. Using a minimally approach reduces length of stay. Conduits, I know there are a lot of conduits around tubular system. We did a lot of work on them and found that actually, in some way, I personally find them difficult because as the tumor resects, the conduit becomes very loose and starts moving. I know you can fix them, but as you then turn the conduit around, there's increased stress on the surrounding brain. So it's a complementary tool to the microscope. There's the learning curve, and I think the cysts are an excellent to start the learning curve for intraparenchymal tumors. Now I sort of put this slide while I was waiting. I was hearing the previous speaker. This is a trial we are running in the UK. It's called the Future GB trial, which is a functional and ultrasound guided resection of glioblastoma. And this is to try and move the bar beyond the Walter tumor trial, where the study is designed in 2 stages. So the center which start the trial go through a learning phase. This is a randomized trial with 357 patients. Patients are randomized into 2 groups. One group gets neuronavigation. This is for high-grade glioma, the glioblastoma, and 5-ALA. The other group gets high-grade gets 5-ALA, neuronavigation, DTI, and intraoperative ultrasound. The idea is to see that using DTI and intraoperative ultrasound beyond 5-ALA, does it improve the overall deterioration-free survival of these patients? So these are the number of sites open. Kishore is in Sheffield. Sheffield is joining us shortly. This is our present recruitment. The trial will go on for another 1.5 years. Thank you very much. And I'm sorry about this communication, Kishore.
Oh, thank you, Puneet. Thank you for that lovely presentation and excellent demonstration, despite having technical difficulties. So if you can stop sharing your screen, then I'll just quickly introduce our panelists and we can have some quick question and answer session. Puneet, can you stop sharing your screen? Yeah, great. Perfect. Lovely car, by the way.
Good. Fantastic weather.
Okay.
Yeah.
Okay, so we got Dr. Shan Babulkar from Nagpur as the panelist and founder member of our MCNS. We got Jan Mazda Turel as a panelist. We are now accustomed to Mazda because of his terrific writing that we have been reading and appreciating for last several weeks now. And as it goes with the surname, He's so committed to writing, to neurosurgery. And welcome, Mazda. We've got Abida Shah, who herself is a force to reckon with as far as neuroanatomy is concerned. So she's there with us. And we got Dr. Meghna Chowgule from Kolhapur, who is setting a different benchmark for the district places by her very high neuropathological standards. So with that short introduction, can I ask the panel to take over and ask the question to our esteemed speakers. Also, if there are any questions from the audience, please do write them in the chat and we'll pick them up. Sorry, probably they need to be unmuted. Yeah.
The video is also not starting. Can you also start the video, please?
Which video?
No, I can't start the video. Video means I can.
Sorry, the
okay,
video of all the speakers. Can we start the? Can you open the video of all the speakers?
Yes.
We can't keep the speakers on mute. That will be a bit of a problem.
Yes.
Okay.
Yeah.
Yeah.
Please.
We can't still see you, Datta.
And please unmute.
Yeah, but I've started the video. You can see me now. I can see myself. Can you see me?
Not yet.
Yeah, we can see Datta. Datta, you are there. Yes.
Yeah. Here. First. Next.
Okay, so I think let's start with Mazda. Mazda, what do you think about Dr. Majumdar's talk about the supramarginal resection of gliomas?
Yeah, I think, I mean, as a concept, it makes a lot of sense. But and when Dufour started popularizing it, and it works well for tumors that are non-eloquent. But now with this new invasion of connectomics that has come in, and these other networks that we've learned about, the salient networks, the subinsula network, and all the other several networks that we are learning about, even though there may not be any gross motor sensory deficit, even for example, a standard frontal lobectomy, which we do with impunity, leaves a patient with so much of dysfunction in terms of memory, in terms of insight, in terms of judgment, in terms of emotional understanding. And we are only able to now study those concepts with the advent of connectomics. So while supramarginal resection sounds like a really good option, and in a PowerPoint presentation, it looks good where a patient has no motor or sensory deficit, but it sometimes incapacitates the patient so many times. I mean, I've done a frontal lobectomy, patient has no neurological deficit, but the patient will say, okay, sir, wo jaisa tha wo ab raha nahi. And you've done an excellent resection, but we are not able to, are we able to justify? See, I don't think that at the end of even a discussion, you'll have a right answer. Because as with each year that we are progressing, we are learning so much more about the functional networks of the brain rather than the structural networks. And are we able to justify, or does the knowledge of these functional networks change the discussion with a patient on an individual basis? For example, if there's a standard, let's say frontal GBM or a frontal low-grade glioma, for a farmer or for a manual laborer, supramarginal resection may not be a problem. But for someone who's high functioning, who's an executive, for them a supramarginal resection or even a gross total resection for that matter may lead to a disabling life. So I guess every single surgery will now have to be customized to every single patient, and like you rightly said, there is no right or wrong answer to these problems. And every patient now, as Meghna will tell us, the molecular pathology for every patient is like their patient's fingerprint. The molecular pathology of every glioma is now you cannot use a standardized approach for the treatment of these conditions anymore. It is your glioma is different from my glioma, is different from a third person's glioma. So
indeed,
I think
maybe with that, shall we get Datta to speak and say something about and then Meghna?
Yes. So, yeah, I agree with Mazda, and that has been my contention right throughout. To say correctly that non-eloquent and non-dominant frontal lobe is not actually non-eloquent. It could give you massive deficits. And if I may tell you that the neuropsychology, we don't do neuropsychology testing of all these patients. If you do a detailed neuropsychology testing of all these patients, these functional preservation that we are talking of definitely has loopholes. And this I'm telling you right from the neuropsychologists, right? Because we are dealing with, I deal with neuropsychologists in and out for my epilepsy surgery. So what we think, even the section of a colloid cyst for that matter, we see that there are no memory deficits. But if you go and do a detailed neuropsychology, as what Mazda said correctly, is there deficits. And a high functioning individual will definitely say that's something with me.
Okay. Meghna, you have to say
India from the thing we are saying, or this thing, so they might not come out with the which I showed you about supramarginal section. There is no, these are all.
Can we? Sorry, you're breaking up, Datta. You're breaking up. We can't hear you.
No currents. There is. Can you hear me now? I think it's
just about. But can someone unmute Dr. Meghna Chaugule and Dr. Shyam Babulkar as well? And can you unmute
Meghna is already unmuted.
Yeah. Am I audible?
Yes.
Yes, you're audible.
May I speak, please?
Yes.
Yes, sure.
Right.
So until this new WHO came up, that is CNS WHO 5, we used to previously classify gliomas, basically diffuse gliomas. We had this wild type and IDH mutant type. Now all the IDH wild type astrocytomas, they are glioblastomas. So a tumor which is even looking low grade, that is, it may be grade 2 or 3, but if it does not show IDH mutation, it is directly upgraded to a glioblastoma. So this is what which we did not have till in our previous, that is 2016 WHO. Now, depending on the IDH status, when the tumor is IDH positive, that is IDH mutant, it is graded as astrocytoma grade 2, 3, and 4. Now, it is very essential to get done the IDH status because the prognosis and the overall survival of the patients, it depends on this. So if the patient is, say, astrocytoma grade 4, that means he's showing the IDH mutation. Now, the survival in these patients is almost, you can say, around 3 years. But if the same patient, if a patient does not show IDH mutation, that is, it's wild type, it's a glioblastoma, then the survival, you all know, it is almost 10 to 15 months. So this is how each patient is very different, and it is very important to get the, you can say, molecular or basic even IHC tests done, which will let us know the overall survival and prognosis of the patient.
Thank you very much, Meghna, for the wonderful comments, very insightful comments. And Dr. Shyam and Abhida, have you got to say anything or ask any questions or make comments? Please come in. Both of
Sir, please unmute yourself. Actually, we have sent you a request. Actually, please unmute yourself. We will send you the request.
In the meantime, Abhida, fire away.
Yeah. So that was a great presentation. And now basically we have to have a kind of an individualized strategy for even resection of gliomas. And probably before embarking on the surgery, study it anatomically and functionally well, and to understand that and then go ahead with the surgery, because you just cannot say, I will do this. You cannot plan it. Of course, awake surgery and monitoring helps to plan your resection. My question is, if there is an awake surgery, would it deter you from performing a maximum resection? To all the speakers, if you're doing an awake surgery, how do you balance between doing a maximum surgery, maximal resection in an awake condition? I mean, do you end up not removing enough tumor, or
I think I echo Abhida's sentiments and worries as well. I am always worried that will awake surgery compromise on surgical resection. I don't mind having some minor neurological deficit post-op, which you are likely to improve, especially if you've taken the tumor out. And I'm always concerned that awake surgery will stop me doing that. So maybe over to you, Ali. Have you got anything to say about this? And then Punit.
Okay. So I think very interesting conversation and discussion which Mazda actually initiated. So a couple of comments before I come to that, addressing that question, is that, many years back, if you see the series historical of glioma outcomes, they never discussed morbidity. They only reported mortality. Means the goalpost at that time was preserve life. Then a few years, decades down the line, you started having series of gliomas reporting morbidity, which means that we had overcome the problem of saving lives, but now we're more interested in motor function. And now we are in the era where we have reached a position where we can reliably preserve gross motor function, gross neurological function, but now we are looking to preserve even beyond that. The question is, if you are going to look for a deficit, you will probably find one. And if you don't look for it, you would relax saying that, okay, there is no problem and that we've achieved our intention. So I would say that if we agree on the principle that we want a safe and a maximal resection, then I think the question which Abhida asked is actually a non-question. That if you are going to get a positive mapping in a vital area, then you would want to stop short of that because you want to preserve the function. It's a question of how much of trade-off of a deficit you will have versus achieving the gross total resection. And it's with what reliability can you predict whether the deficit that you will have will be reversible. I won't say that I have a 100% answer for that, but definitely doing mapping and doing mapping correctly. And this is important. The mapping has to be done correctly. When you keep the patient awake and you just monitor the patient and don't map, and a lot of people actually claim they do awake surgery by just keeping the patient awake and assessing the function. That's monitoring. That's not actually mapping, because mapping preempts the onset of the deficit. And if you're only monitoring the patient awake, you will land up with a deficit. Patient is showing you a deficit, and then that's irreversible. That's not the right way of doing it. So therefore, if you do it correctly, the techniques have to be followed correctly, and they are designed in a way so as to give you the maximal benefit. So I would still say that yes, whereas it is true that awake surgeries, the criticism is that you might stop short, but if done correctly, the aim of the surgery is to let you when to stop. And it's up to you to decide if you want to stop and accept that subtotal resection or go ahead and accept the deficit. So I think I will open it to the others and for a discussion. It's an interesting and a controversial point that we can discuss.
Dr. Shyam, you have unmuted yourself, so do you have anything to say?
Yeah. Hello, can you hear me?
Yes.
I am audible?
Yes.
Hello.
Yes, you are.
Yeah. In the whole treatment of glioma, which is almost not changed much in last 20 years, and Datta also told that the more focus should be on less morbidity than mortality, because with extreme morbidity and grade 0 hemiplegia and aphasia, if patients survive for another 2 years, no meaning to that. So less morbidity and without scaring of the mortality. Second thing, can Meghna suggest that during operation can we do grade 3 glioma if there, and grade 4 glioblastoma is less sensitive to radiation. Is there any process of mutation that cells can be more perceptive, more sensitive to radiation, and the result of radiations is better, or chemotherapy? Is it possible?
So do you mean that can we have any mutational analysis during intraoperative? Do you, I did not
Probably
get the
not.
question, sir. Yes.
I think that's what he means, probably, Magda. Yeah, that's correct.
No, sir, that cannot be done. But looking at on the frozen section, seeing the cytomorphology, we can definitely tell you whether it is a low grade or a high grade glial tumor. So mutational or genetic analysis or even immunohistochemistry, though some centers, they have tried doing liquid IHCs on the liquid based tissue, but that actually doesn't matter. We can give you the report whether it's a high grade or low grade only on frozen or the squash smears. Mutational studies are not possible.
Yeah, thank you.
Sorry, any more questions? Any more comments?
Can I add something?
Yeah, surely.
I
Who's
just
that?
want.
Oh, yeah, Puneet, go ahead.
Yeah, hi, thank you. I just wanted to add a couple of things to the discussion here. Firstly, on the supramaximal resection, I would agree with some of the comments here. I think doing a flare resection is the wrong concept to be sold. The concept in glioma surgery, even with high-grade glioma, should be functional resection. So we looked at some where you see a post-contrasting tumor and the flare is beyond it. The question is, what are the white fiber tracts doing in relationship to the flare signal? If your white fiber tracts are going through the flare signal, my view is you cannot resect those white fiber tracts. Giving patient a neurological deficit in the present scenario, I think is the wrong thing to do for high-grade gliomas because it certainly affects their recovery and their survival. So I think the discussion should not be flarectomy, it should be functional resection. Secondly, I agree with some of the comments said earlier. If you're doing an awake surgery, and we do a lot of it, we use 5LA fluorescence, we use DTI for every case, we use intraocular ultrasound, where your subcortical mapping picks up either a speech fiber tract or motor. Even if your 5LA fluorescence signal is positive, we stop. It is not acceptable again to give somebody a deficit. There was a paper we published in Journal of Neuro-Oncology last year, which looked at speech deficits and motor and optic nerve deficits following awake surgery. What we tell patients that if they're going to have an awake surgery around the speech areas, the chance of a temporary speech deficit, neurological deficit after surgery is almost 40%. The more you look, the more you find. All of these patients have a preoperative full neuropsychology and a postoperative one. If you don't look for it, you won't find it. The chance of a permanent deficit is about 4% at 3 months. And this we've shown with postoperative DTI scan. So I agree with some of the discussions earlier. If you're doing awake surgery with rigorous assessments, you will have deficits on your patients, cognitive, memory, and speech. If you don't do an assessment and you just look at motor, then everything is good. That's all I wanted to say. Thank you.
Thank you very much, Puneet. Wonderful comments. Any more questions? We don't have any questions in the chat.
Can I ask one question?
Yes, Suresh.
Yeah, for Puneet. Puneet, your presentation was impressive as usual. Just briefly, I would like to say that, what is the big advantage of using the endoscope for Lobar tumors? I agree with you, all those deep-seated tumor, there's a great advantage of using the endoscope and, go after the tumor, and remove it completely. But for the Lobar tumor, which are very superficial and all that, how do you think it is different than the microscopic resection?
Suresh, I agree with you. There is not much of an advantage. If you have a Lobar tumor with a good cortical presentation, your craniotomy has to be bigger than the cortical presentation. So there, the advantage of the endoscope is really diminished in compared to the microscope. I agree with you. But for the deep ones, as I've shown some of the example, I think there is some advantage. Now, I'm sure there are many ways to skin a cat. Some of you would say you can do that with a microscope. I'm not disputing it. I'm just giving a different angle of doing the same thing. So I agree with you, Suresh.
Thank you. Thanks.
I think it's 1.5 hours since we started, Suresh. So probably we are running out of time. Our discussion will go on for for a long time if we allow it to continue. So however interesting it is, I must say that we need to call it a day. And can I get Sarang to just say a vote of thanks to everyone who participated?
From the MCNS webinar team, I would like to thank all the faculties for their impressive presentation and a wonderful discussion. I would also like to thank the MCNS EC committee for giving opportunity for the webinar, and also thank for all the audience. Thank you.
With that note, and with Suresh's permission, can we say that the webinar is over? And
yes,
good evening, good night.
Thank you. Thank you very much, Kishore.
Thank you.
Thanks,
Good night.
everybody.
Good night, everyone.
Thank you.
Night,
Okay, bye-bye.
Bye.
Thank you, everybody.
Thank you.